This is a review from class, Fluid Regulation, Chapter 17, Lewis textbook. Body fluids and electrolytes play an important role in maintaining homeostasis. Fluids transport nutrients, electrolytes, and oxygen to cells as well as carrying waste products away from the cells. Water content in an adult constitutes 50 to 60% of body weight. The percentage decreases to 45 to 65% in the older adult, and so that's why it puts an elderly population at a risk for fluid imbalance. The more fat content in the body, the less amount of water. Men typically have leaner muscle mass and they have a higher percentage of water than women. Approximately 2/3 of the body water is located within the cells and is termed intracellular fluid. The other 1/3 of body water is located outside the cell, and this is known as extracellular fluid. The extracellular fluid consists of three types: interstitial, which is fluid located in the spaces between the cells and the lymphs; intravascular, which is the fluid portion of the blood known as plasma; and transcellular. This refers to a very small amount of fluid contained within specialized cavities in the body. This would include cerebrospinal fluid, fluids in the GI tract, pleural, synovial, peritoneal, intraocular, and pericardial fluid. About 2/3 of the extracellular fluid is in the interstitial space and 1/3 is intravascular. The fluid in the intracellular spaces totals about 1 liter at any given time, but because 3 liters to 6 liters of fluid is secreted into and reabsorbed by the GI tract every day, loss of this fluid from vomiting or diarrhea can produce serious fluid and electrolyte imbalances. Ions are electrically charged particles. Cations are positively charged ions. Examples would be sodium, potassium, calcium, and magnesium. Anions are negatively charged ions, and examples would be bicarb, chloride, and phosphate. A cation and anion combine within the body fluids to maintain electroneutrality. Examples include sodium bicarbonate, sodium chloride, and potassium chloride. Electrolyte composition does vary between the intracellular and the extracellular fluid. The main cation in the intracellular fluid is potassium, with small amounts of magnesium and sodium. The main anion is phosphate, with some protein and a small amount of bicarbonate. Now the main cation in the extracellular fluid is sodium, with small amounts of potassium, calcium, and magnesium. The main anion is chloride, with small amounts of bicarb, sulfate, and phosphate. Antidiuretic hormone is produced by the hypothalamus, stored in the pituitary gland, restores blood volume by increasing or decreasing excretion of water. Increased osmolality or decreased blood volume will stimulate the release of antidiuretic hormone. Then the kidneys can reabsorb the water. It can also be released during stress, pain, or surgery. The single most important effect of an antidiuretic hormone is to conserve body water by reducing the loss of water in the urine. Capillary pressure forces fluid through the walls and into the tubules. At this point, water or electrolytes are either retained or excreted, and the urine becomes more dilute or more concentrated based on the needs of the body. This visual demonstration of diffusion is a movement of molecules from an area of higher concentration to an area of lower concentration. Movement stops when the concentration equalizes. This process allows small molecules like oxygen and carbon dioxide to cross the plasma membrane. Most polar molecules, such as sugar and proteins, can't freely cross this lipid membrane. Osmosis is the movement of water through a semi-permeable membrane that does not allow solutes to cross. Osmosis is the movement of water through a semi-permeable membrane that does not allow solutes to cross. Water moves from the less concentrated side, has more water, to the more concentrated side, which has less water. It requires no energy, and the water movement stops when the concentration differences disappear or hydrostatic pressure builds sufficiently to oppose any further movement of the water. If a molecule such as urea is added to one side of the membrane, it will not be able to diffuse across the membrane because it is both large and polar. Because of its polar nature, it will interact with other polar molecules such as water. This interaction reduces the number of free water molecules on the right side. If the osmotic concentration of two solutions are equal, then the solutions are considered isotonic. When the solutions have unequal osmotic concentration, then the solution with the higher concentration of solutes is hypertonic, and the solution with the lower concentration of solutes is hypotonic. The sodium-potassium pump. Active transport uses external energy to move molecules against the concentration gradient. from an area of low concentration to an area of high concentration. An example of active transport is a sodium-potassium pump. ATP is used to move the sodium out of the cell and potassium into the cell. Osmotic pressure is measured in millimoles and may be expressed as either fluid osmolarity or fluid osmolality. Although osmolality and osmolarity are often used interchangeably, osmolality is used to describe fluids inside the body and osmolarity pertains to fluids outside the body. Fluids with the same osmolality or tonicity as the cell interior are termed isotonic. There is no fluid movement between isotonic fluids. Effects of water on red blood cells. An easy visual to understand is the impact of tonicity on fluid movement is to picture what may happen to a red blood cell when you administer different IV fluids. Isotonic fluids will have no impact on the red blood cells. If a cell is surrounded by hypotonic fluid, water moves into the cell, causing it to swell and possibly to burst. If a cell is surrounded by hypertonic fluid, water leaves the cell to dilute the extracellular fluid, and the cell shrinks and eventually may die. Hydrostatic pressure is the force within a fluid compartment. In the blood vessels, hydrostatic pressure is the blood pressure generated by the contraction of the heart. At the capillary level, hydrostatic pressure is the major force that pushes water out of the vascular system and into the interstitial space. Oncotic pressure is the osmotic pressure caused by plasma colloids in the solution. This is also called colloidal osmotic pressure. The plasma protein molecules attract water, pulling fluid from the tissue space to the vascular space. Capillary hydrostatic pressure and interstitial oncotic pressure move water out of the capillaries. Plasma oncotic pressure and interstitial hydrostatic pressure move fluid into the capillaries. If there are changes in capillary or interstitial pressures, fluid may shift abnormally from one compartment to another, resulting in either edema or dehydration. When capillary hydrostatic pressure rises, the plasma oncotic pressure decreases, or interstitial oncotic pressure rises. The fluid shifts into the interstitium and causes edema. Edema may also develop if an obstruction of the lymphatic outflow causes decreased removal of the interstitial fluid. When plasma oncotic pressures increase, fluid is drawn from the interstitium into the plasma space. This can occur with administration of colloids, dextran, mannitol, or hypertonic solutions. Also, an increase in tissue hydrostatic pressure can cause a shift of fluid into the plasma. The application of elastic compression gradient stockings to decrease peripheral edema is a therapeutic application of this effect. Now, fluid spacing is the distribution of body water. First spacing is the normal distribution of fluid in the intercellular fluid and extracellular fluid compartments. Second spacing is an abnormal accumulation of interstitial fluid, like edema. Third spacing, when fluid accumulates in portions of the body from which it cannot easily exchange with the rest of the extracellular fluid. Third space fluid is trapped and unavailable for functional use. Ascites is an example of third spaced fluid. An intact thirst mechanism is critical because it's a primary protection against the development of hyperosmolality. Osmoreceptors in the hypothalamus sense a body fluid deficit or increase in plasma osmolality, which in turn stimulates thirst and antidiuretic hormone release. Thirst causes the patient to drink water. ADH, also called vasopressin, which is synthesized in the hypothalamus and stored in the posterior pituitary, will then act in the renal distal and collecting tubules, causing water reabsorption. If the plasma osmolality is decreased or there is water excess, secretion of ADH is suppressed, resulting in urinary excretion of water. Renal regulation. The kidneys regulate water balance by adjusting urine volume and the urinary excretion of most electrolytes to maintain a balance between overall intake and output. In the average adult, the kidney reabsorbs 99% of this filtrate, which produces about 1.5 liters of urine a day. With severely impaired renal function, the kidneys cannot maintain fluid and electrolyte balance. This results in edema, potassium and phosphorus retention, and acidosis. Adrenocortical regulation is when the glucocorticoids and the mineralocorticoids secreted by the adrenal cortex help regulate both water and electrolytes. The glucocorticoids, like cortisol, primarily have an anti-inflammatory effect and increase serum glucose levels. The mineralocorticoids, like aldosterone, cause sodium retention and potassium excretion. Water is retained with the sodium. In large doses, cortisol has both glucocorticoid, which is glucose elevating and anti-inflammatory, and mineralocorticoid, which is sodium retention effects. Decreased renal perfusion or decreased sodium delivery to the distal portion of the renal tubule activates the renin-angiotensin-aldosterone system. This results in aldosterone secretion, increased serum potassium, decreased serum sodium, and release of adrenocorticotropic hormone, ACTH, from the anterior pituitary also stimulate release of aldosterone. The cardiac regulation of water balance is the natriuretic peptides, including atrial natriuretic peptide and B-type natriuretic peptide, are hormones produced by the cardiomyocytes. They are natural antagonists to the renin-aldosterone-angiotensin system and are produced in response to increased atrial pressure and high serum sodium levels. They suppress secretion of aldosterone, renin, and antidiuretic hormone and the action of angiotensin II. In the renal tubules, these peptides promote excretion of sodium and water, which results in a decreased blood volume and pressure. The gastrointestinal regulation. Water intake also includes water present in solid foods. Lean meat is approximately 70% water, whereas the water content of many fruits and vegetables approaches 100%. In addition to oral intake, the GI tract normally secretes about 6 to 8 liters of digestive fluid each day that is reabsorbed. Diarrhea and vomiting, which can prevent GI reabsorption of this secreted fluid, can lead to significant fluid and electrolyte loss. Insensible water loss is the invisible evaporation from the lungs and the skin that normally regulates body temperature. Normally about 600 to 900 mL a day is lost. Accelerated body metabolism, which occurs with increased body temperature and exercise, increases the amount of water loss. Insensible perspiration causes only water loss. Excessive sweating caused by exercise, fever, or high environmental temperatures can lead to large losses of water and electrolytes. So what can affect homeostasis? Illness, trauma, dehydration, vigorous exercise. But thirst is a primary regulator of water intake. It's an important role in maintaining fluid balance and preventing dehydration. The thirst center in the brain is stimulated when the blood volume just drops because of water losses or when serum osmolality increases. Kidneys are primarily responsible for regulating fluid volume and electrolyte balance in the body, and this is done by controlling the excretion of water and the electrolytes. About 170 liters of plasma are filtered through glomeruli every day. Renin maintains intravascular fluid balance and blood pressure. If there is a decrease in blood flow or blood pressure, the kidneys release renin, converted to angiotensin I, which is a plasma protein, in the bloodstream. Angiotensin I is converted in the lungs with the help of angiotensin-converting enzymes to angiotensin II, which is a potent vasoconstrictor, raising the blood pressure. Also stimulated is a thirst mechanism to increase the fluid intake. Angiotensin II stimulates the adrenal cortex to release aldosterone, which promotes the sodium and water retention by the kidneys and restoring blood volume. Antidiuretic hormone, released by the posterior pituitary gland, regulates water excretion from the kidneys. The decreased blood volume stimulates the secretion of ADH, which acts on the kidneys to increase water reabsorption. This decreases urine output, and serum osmolality decreases, and as water dilutes body fluids, returning them to normal. Atrial natriuretic peptide is a hormone released by the atrial muscles of the heart in response to fluid overload. It actually stops renin to prevent the release of aldosterone. It promotes sodium wasting and diuresis, causing vasodilation, and the fluid and electrolyte imbalances occur to some degree in most patients with a major illness or injury because illness disrupts the normal homeostatic mechanism. These imbalances can be directly caused by illness or disease or by therapeutic measures such as IV fluid replacement or medications. The imbalances are commonly classified as deficits or excesses. In actual clinical situations, it is common for more than one imbalance to occur in the same patient. For example, a patient with a prolonged nasogastric suction will lose sodium, potassium, hydrogen, and chloride. and these imbalances may result in deficiencies of both sodium and potassium. Hypervolemia is fluid volume excess, and it means all the vessels are filling with fluid. Too much volume in the vascular space. Any vessel in your body, whether it's a vein, capillary, or artery, is part of the vascular space. When it leaks into the tissue. Fluid volume excess is filling the vascular space up first, then it goes into the tissue, and that is when you see edema. The chambers of the heart are filling up with fluid as well as the vessels, and the cardiac output is down. You will see distended neck veins and peripheral veins because the vessels are full of fluid. Peripheral edema and third spacing can occur because the vessels cannot hold any more, so they start to leak. If someone is bed rest, the edema begins to form in the sacral area. So think about what happens to the tissue in the sacral area. It begins to break down. Lung sounds with fluid volume excess can sound adventitious, crackles, wet. Nursing management. You'll see a weight gain of greater than 5% in a short period, full bounding pulse, distended neck veins, and peripheral veins. There's an increase in central venous pressure, dyspnea with a cough, moist crackles, pulmonary edema, polyuria, could have ascites, peripheral edema, and if severe, anasarca. Sodium and water retention could be caused from too much intake or impairment of the mechanism that maintains the homeostasis. So you could see heart failure, cirrhosis of the liver, renal failure, adrenal gland disorders. Other causes could include excessive sodium intake and fluid intake. Sodium retaining medications. Diuretic therapy is intended to treat fluid volume excess, but over-administration of diuretics could result in fluid volume deficit. So loop diuretics like Lasix or Bumex inhibit sodium and chloride reabsorption, promoting the excretion of sodium, chloride, potassium, and water. Thiazide diuretics promote the excretion of sodium, chloride, potassium, and water by decreasing absorption. Potassium-sparing diuretic promote excretion of sodium and water, but retain the potassium. A fluid restriction would be to decrease the fluid intake, including IV solutions. Fluid restriction would be to decrease the fluid intake, including the IV solution. PO would probably be ice chips only. Patient would need mouth care and maybe some gum to help with the dry mouth. Dietary could either be no sodium or a 2-gram sodium a day. In a nutshell, patient would get a low sodium diet, assess their vital signs, elevate lower extremities, daily weights, intake and output, diuretics, assess the skin, reposition every 2 hours, and monitor oxygen saturation. Fluid volume deficit. There are several causes of fluid loss like vomiting, diarrhea, gastrointestinal suctioning, intestinal fistulas, intestinal drainage, diuretic therapy, renal disorders, endocrine disorders, sweating from excessive exercise, increased environmental temperature, hemorrhage, chronic abuse of laxatives. That's a lot. And then there's degrees of shock. So with hemorrhage, the patient would be losing fluid directly out of the vascular space. Another way to become hypovolemic is third spacing, and that's where the fluid is going where it has no business being, like ascites. It can take 20 minutes of poor perfusion of the kidneys for acute tubular necrosis to occur. So if the kidneys do not receive perfusion, they're going to conserve, and then they're going to become oliguric and then anuric. Weight can go down, decreased skin turgor, central venous pressure can go down, less volume, less pressure. They'll have small peripheral veins, cool extremities, urine-specific gravity is increased and concentrated. So treatment for fluid volume deficit, oral, IV, or enteral routes. Manage the effects and prevent further complications by monitoring their intake and output, assessing their lab values, observing their vital signs and skin integrity. Fluid volume deficit can occur from loss of normal body fluid that occurs with vomiting, diarrhea, fistula drainage, hemorrhage, and diuresis. It can also occur secondary to disease processes like diabetes insipidus, burns, hemorrhage, or intestinal obstruction. The term fluid volume deficit should not be used interchangeably with the term dehydration. Dehydration refers to a loss of water alone without corresponding loss of sodium. Clinical symptoms include restlessness, drowsiness, lethargy, confusion, postural hypotension, tachycardia, tachypnea, weakness, dizziness, weight loss, seizures, coma. Skin turgor and capillary refill and urinary output are all decreased. Balanced IV solutions, such as lactated ringers, are usually given to replace both water and any needed electrolytes. Isotonic sodium chloride is used when rapid volume replacement is indicated. Now, blood is administered when volume loss is usually a result of blood loss. Nursing management. Compare and contrast nursing diagnosis for hypovolemia and hypervolemia. This patient is at risk for hypovolemic shock if fluid loss continues without replacement. The patient with hypervolemia has excess fluid volume related to increased water or sodium retention. This patient may also have impaired gas exchange related to water retention leading to pulmonary edema. Peripheral edema increases the patient's risk for impaired skin integrity. Increased water retention, fatigue, and weakness can lead to activity intolerance. So the appearance of edema can affect the body image. And finally, a patient with excess fluid volume is at risk for pulmonary edema and ascites. The care of a patient with either a fluid deficit or excess requires astute attention to their fluid volume status. This includes careful monitoring of I's and O's, and the intake includes all oral, IV, enteral, and retained irrigants. Output includes urine, excessive perspiration, wound or tube drainage, vomitus, and diarrhea. Urine-specific gravity may also be measured. Readings of greater than 1.025 indicate concentrated urine, whereas readings of less than 1.010 indicate dilute urine. Cardiovascular signs and symptoms of extracellular fluid volume excess and deficit are reflected in changes in the blood pressure, the pulse force, and jugular venous distension. Orthostatic hypotension may be evident in patients with fluid volume deficit. Both fluid excess and deficit affect the respiratory status. The extracellular fluid excess can result in pulmonary congestion and pulmonary edema as increased hydrostatic pressure in the pulmonary vessels forces fluid into the alveoli. The patient will experience shortness of breath and moist crackles on auscultation. Changes in neurological function could occur with fluid volume excess or deficit secondary to either cerebral edema or reduced cerebral tissue perfusion. Assessing the patient's level of consciousness, pupillary response, and voluntary movement of extremities. Detect clues to extracellular fluid volume deficit and excess by inspecting the skin. Examine the skin for turgor and mobility. Normally, a fold of skin, when pinched, will readily move and on release will rapidly return to its former position. Skin areas over the sternum, abdomen, and anterior forearm are the usual sites for evaluation of skin turgor. In extracellular fluid volume deficit, skin turgor is diminished and there is a lag in the pinched skin fold return to its original state. This is referred to as tenting. Decreased skin turgor is less predictive of fluid deficit in older persons because of the loss of tissue elasticity. Mucous membranes may be dry and the tongue furrowed with fluid volume deficit. Fluid volume excess will demonstrate edema. Assess edema by pressing with the thumb or forefinger over the edematous area. A grading scale is used to standardize the description of indentation, ranging from 1+ slight edema, which is about 2 mm indention, to 4, which is pitting edema, which is a 9 mm indention. Good skin care, though, is a priority for patients with fluid imbalances.